Good afternoon and welcome back. I hope everybody had a terrific lunch. Good. So, I'm introducing the next presenter who I have had the pleasure of knowing since high school. Yes. Steve and I went to high school together way back when, and though we did lose touch over the years, unfortunately, though he had met my mother, he never got to see firsthand the ravages and effects of this disease as they impacted her. But when we did connect years later through the magic of the internet, he did not hesitate to accept my invitation to join our board. Steve is now a interventional radiologist, did I get that right? In Florida, and he has come up all the way from Boca to attend and present at his first MSA conference. So without further ado, Dr. Stephen Borstelmann.
Hello, everybody. I'm going to talk about the road to diagnosis of MSA. Some of you have had a firm diagnosis of MSA. Some of you may be in the process of a diagnosis. Some of you may or may not know if you fall into the category of MSA and which category of MSA that you do. I'm going to give a little bit of a historical discussion of this, and I will try not to bore you with too much neuroanatomy, just enough so that you understand what's actually happening in this disease. I'm going to first do the usual disclosures. I actually have nothing to disclose. I'm not being paid for this speech. I don't get speaking fees, consultant fees, or anything on that order. I should probably discuss that I do have stocks in my 401k, some of which probably are like GE and in the mutual funds that I own, and they do involve themselves in therapies that could be applicable to MSA. Honestly, I don't know what I own. And I'm going to just, because this is New Jersey, I'm just going to say that this presentation is made on a compassionate basis for educational purposes only. It's not intended to replace an existing relationship with your treating physician or recommend any change to treatment plans. If there's any information that I'm giving you that contradicts what your doctor is saying, go with them. So I'm going to start first with neuroanatomy, and I'm going to ask you to imagine that you take a guillotine and drop it on someone's head right in the middle, okay? This is what you would get. The blue part is what we all think of as brain. The blue part is the cerebrum. This is the advanced thinking machine that is our wonderful brain that we think about as our brain. This is actually the newest portion of the brain, though. The older portions of the brain are the areas that have been involved by MSA. I would like you to take a look at the purple area. The purple area is our hindbrain, or our lizard brain. This is the area consisting of three areas: the midbrain, the pons, we call that the pregnant belly of the pons. I'm going to see if I can, or if you prefer, the beer belly of the pons, so we're not sexist. And the area that's lower is the oldest area of the brain, the medulla. This is the area of the brain that concerns itself with autonomic function, that concerns itself with the most basic of movements that are our cranial nerves, nerves that are involved in with our eyes and our face. The area that's right behind it, the red area, is called the cerebellum. The cerebellum is a portion of the brain that is involved in motion, complex motion, playing the piano, sports, walking. Finally, the orange area, which is kind of a little bit hidden, is an older area of the brain, but not as old as the purple area. This is called the telencephalon, and it is composed of a number of structures that can also be affected in MSA. Because one of the subtypes of MSA can be confused with Parkinson's disease, it's relevant to discuss the etiology of Parkinson's and where it lives. Parkinson's disease is a disease that affects predominantly the substantia nigra in the brain, and this is at the level of the midbrain. If we go back to the slide that we just had previously. And up here, instead of going down halfway with our guillotine through the body, we go across like you're actually chopping someone's head off. We would see this area right in the center. And this black substance, which is the substantia nigra, these are the dopaminergic neurons that are affected in Parkinson's disease, which die off, okay? And in Parkinson's disease, you will see at the bottom, there is a lack of that black substance, substantia nigra, black substance, that dies off and creates Parkinson's disease. I alluded to the not as old section of the brain. And if we were to take a slice through the brain at about the level of the temples, using our guillotine again, apologies to the French, we would see this structure. And these older areas of the brain are together called the lentiform nucleus. And it consists of at least 4 structures. The large purple caudate nucleus, which is comma-shaped or C-shaped. The red thalamus, which almost looks like a barbell or a dumbbell. Those areas are relevant, okay, but they're not implicitly implied to be affected in MSA. What is relevant are the areas of the putamen and the globus pallidus. The putamen is the darker green structure, which is more lateral, more towards the outside of the brain. And the globus pallidus is the area that is more inside, more toward the center of the brain. So you've made it all through neuroanatomy, and you're all experts now. So from the radiologist's viewpoint, we have had a number of different syndromes that describe different things that we see in the brain. And they correspond to multiple system atrophy subtypes. Multiple system atrophy subtype C is a disease that we refer to as olivopontocerebellar atrophy. Well, what does that mean? Well, that means we saw wasting in the olives, the pons, and the cerebellum. And that was one subclass. MSAP is the Parkinsonian subset of MSA, which has Parkinson's-like syndromes and has also been called in the past striatonigral degeneration. I will include, even though it's not canon any longer and it's been specifically thrown out, Shy-Drager syndrome, or MSA subtype A, in which the autonomic syndromes predominate. That is no longer included in the definition of MSA, as both MSA-C and MSA-P have the autonomic system symptoms included. So I'm going to talk a little bit about what might happen if you were a patient that had MSA and you present to the ER or to your primary care practitioner with symptoms. What is the flow chart? What are the paths that you are going to go down? So most of the neurologic workup starts with a CAT scan. And depending upon what we find on that CAT scan, either yes or no, if you don't have any findings on the CAT scan, it's actually probably a little bit more suggestive of MSA than it is not of MSA. A CAT scan is there to exclude a large brain hemorrhage, a stroke, subdural hematomas, something that's large and obvious. Subtle findings that you see in the neurodegenerative disorders will simply not be present on a CAT scan. So after that, you are going to be referred to a neurologist if you have neurologic symptoms and they're not easily just slotted into a clear diagnosis. And with the neurologist evaluation, that's going to be a fundamental part of the evaluation and diagnosis and ultimately treatment of MSA. And as we saw in my colleague's discussion this morning, which was very comprehensive and very good, the neurologist is an integral part of the MSA patient's life. The first thing a neurologist is usually going to do is get an MRI of the brain and possibly the spine, depending upon the presenting symptoms. The MRI of the brain is I'm going to go into this a little bit later, but the MRI of the brain will hopefully show some of the findings of MSA. MRI of the spine is not going to really show much, okay, but it's useful for what it excludes. Discs, tumors, arteriovenous malformations. When the spine is not really contributory, we can then focus on what we call a supratentorial or in this case, it really is a peritentorial process, a diagnosis in the calvarium itself. So if there are cerebellopontine findings, and what I mean by that, if there are findings that exist in the cerebellum and the pons, we can be reasonably certain in correlation with the autonomic nervous system findings that will be present on clinical evaluation that this is a MSA subclass C. Diagnosis obtained, stop. If there are not classic cerebellopontine findings, the question is raised, are there Parkinson-type symptoms? If not, well, maybe it's not MSA. Maybe it's something else. But if there are Parkinson-type symptoms, does the patient have a poor response to levodopa? Yes. Then we are suspicious of MSA subtype P, the Parkinsonian variant. At any time, it's possible to go back to, well, we don't think this is MSA, or, we think we should have more clinical evaluation or different tests. And what I'd like to emphasize in everybody who's here is that the diagnostics process may not be straightforward or quick. Your disease is going to do what it's going to do. And unfortunately, we can only see the signs and symptoms that are present at that time. But ultimately, in the fullness of time, a classic pattern will ultimately emerge. So when we do the CAT scan of the brain, what we are looking for is to exclude mimics of MSA, significant neurological diseases, brain hemorrhages, infiltrating tumors of the pons or the midbrain, hemorrhages, subdural hemorrhages that are bilateral. Just a quick survey of the brain. And if you've ever had a CAT scan, it's basically pretty quick. You lie down, the machine whirs around you, okay? Depending upon how the CAT scan is ordered, you may have an injection of contrast. This contrast is generally safe unless you have problems with your kidneys, which you should let us know about beforehand, or you've had an allergic reaction, which occurs, I think the last number I saw was 1 in about 200,000 people. Most allergic reactions are mild, but once you've had an allergic reaction, you don't want to have another study without being premedicated to depress your immune system for a more serious allergic reaction that could potentially happen. So you've gone through the CT scan, and now you're going to go for your MRI. The MRI is a different imaging mechanism than a CT. Whereas a CT uses ionizing radiation, X-rays, the MRI will use quantum physics. Basically what we do is we put you in a very, very strong magnet, okay? We align all your protons in your body a certain way, and then we hit it with radio frequency pulses and listen to the changes that occur. And that allows us to reconstruct the different tissues in your body based upon their water density, because most protons in your body are water-bound. The advantage of MRI is that it's non-ionizing. It's done without radiation. We will probably use a contrast agent, one of the gadolinium contrast agents, to ascertain if there's something more significant in your brain. A mimic, like multiple sclerosis, a tumor in your brainstem. Things like that that could present in a similar fashion to MSA, but are actually not MSA. I will warn you that everybody's disease is different. Your disease may not have read the textbook. It may not decide to be easy, okay? Please have pity upon your poor doctors. If we scan early, the scan may be unremarkable. Imaging findings may parallel or lag clinical presentation. If this is not like it's all in your head. I mean, technically, yes, it is all in your head. But just because we can't see it on the CT or the MR doesn't mean those symptoms are not present. It simply means that there is not enough information to reliably make that diagnosis at that time. The solution for that is follow-up. Follow-up clinical evaluation and follow-up imaging. Now, I will make my little plug here. And yes, you did hear right, I am an interventional radiologist. So I'm actually going to undercut myself a bit. I believe that for best results, you should have a specialty read by a neuroradiologist. A neuroradiologist is a radiologist who's done additional fellowship training for 1 to 2 years, only reading brains and spines and studies of the nervous system. Many practices will have neuroradiologists, many practices, larger practices will almost exclusively use radiologists these days to interpret their MRIs. But you want a good quality interpretation, and I think you have your best chance of getting an excellent quality interpretation for a subtle finding in the brain on a rare disease with a neuroradiologist. Also, okay, not all magnets are created equal. There is a broad spectrum of magnets that are installed in the community. Some of these are high-quality magnets, 1.5 Tesla, 3 Tesla, closed neuro magnets. Some of these are not as high quality. They're older magnets that have been largely used for orthopedic work, spines and ankles, shoulders, things like that. While an MRI from anything is probably going to be decent, for a rare disease with subtle neurologic findings, you want a good magnet. Not all magnets are created equal. Finally, you're going to go into this magnet. It is going to be loud. It might be a little warm. It's certainly going to be a little bit tight, okay? And you're going to hear a lot of clicking and clacking and blah, 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 blah. Don't move. Motion ruins the study. There's a reason we tell you don't move. It's because when you move, we can't see. So try as hard as you can to lie as still as possible. Get the best study for yourself and the best study for diagnosis that you are able to do. Okay, let's go through what you might find in an MRI in a case of MSA. One of the problems with all the neuroradiologics one of the problems with neuroimaging in a rare disease such as MSA is that early, once again, the imaging findings may not be particularly impressive. One of the findings that may be present early is bright signal in the brachium pontus or the pons. And let me explain what that is. We'll go back to this first slide. And if you recall, here is the pons, okay? What connects the pons and the cerebellum is an arm of neural tissue called the brachium pontus, the arm of the pons. There are 6 connections between the brainstem and the cerebellum. This is the middle one, and it's the largest. The classic finding of MSA and neurodegenerative syndromes such as olivocerebellar-pontine atrophy, Shy-Drager, is the hot cross sign in the pons. It is not specific for any one of these diseases, but it is a very good clue that there is a neurodegenerative process going on. After time, with the process involving the brachium pontis, there will be narrowing of the brachium pontis as neurons and tracts die off. That causes atrophy in the size of the brachium pontis. The cerebellum also atrophies as well. And this is primarily an MSA subtype C. Now, in the area of the brain called the putamen, which I showed you, that intermediate age area higher up in the brain, the putamen itself becomes smaller, especially posteriorly. It has different signal than the globus pallidus. It looks different to a trained neuroradiologist. Finally, to assist, at 1.5 Tesla only, there is a rim of high signal brightness around the posterior putamen, and that is called the putaminal rim sign. It's relevant because the higher field neuromagnets that are 3 Tesla, they can find this on their own normally because the resolution is just better. So here's some pictures so we can discuss and I can show you what we just described. The picture on the left is the hot cross bun sign. And if you can imagine an actual hot cross bun, if you would buy it in the store, you'd have that white cross of frosting. And here is the pons, and there's that white cross of frosting. Okay? And let me orient you. Okay? This here is the pons, and we know it's the pons because there is the black flow void of the basilar artery right in front. These are the tips of the temporal lobes, and here is the cerebellum. Separating the pons and the cerebellum is the fourth ventricle, and we're seeing a portion of it right here. So here, in a cross fashion, we see brightness in the pons, and that is the hot cross bun sign. Turn your attention to the next image on the right, and we have a faint hot cross bun sign there too. It's not as pronounced as the one that I just showed you, but it's still there. But this structure is the brachium pontis. And this structure, all of a sudden, we see is a little bit brighter than it should be. Not only is it brighter than it should be, it's thinner than it should be. How do we know that it's thinner than it should be? Because this area here, which is the fourth ventricle, is far too big. And that is indicative of atrophy. And again, you're seeing a little bit of cerebellum right here. And again, your temporal tips, and you have your eyes here. This little nothing in the fourth ventricle is nothing. It's a flow void artifact. That's why these guys go to imaging, fellowship for 1 to 2 years afterwards to make sure that they don't mistake that for a intraventricular tumor. This is another study. This is taken up higher in the brain itself and at the level of the putamen and the globus pallidus. That's the midline, this is forward, this is back. And the putamen lives right about here. And you're going to have to take my word for it, but it's small, particularly posteriorly. And right here, that little faint bright rim, I believe is a putaminal rim sign. This is a patient with MSA subtype P. Finally, the image on the right is a slice through the brain, similar to the first one I showed you. And take a look at the cerebellum. These are called the foliae of the cerebellum. And the way that the cerebellum is structured, it has frond-like projections. These should be tight, but they're not. There is space in between each other and even going down between the individual fronds. And that is suggestive of cerebellar atrophy. So this is belonging to a patient with MSA subtype C. There are a wide spectrum of variation in cases, and I could show you more in different ones if I had more in different ones, and there just aren't that many that are available for review on the web. It really depends upon where and when you get to us and what we can see. I'm going to bring up PET. PET stands for positron electron tomography. Sorry, positron emission tomography. And it uses a radiopharmaceutical, usually 18-fluorodeoxyglucose. And what this is a metabolite, similar to glucose, but it's uptaken by cells that are metabolizing, but it doesn't break down. It kind of stops there. So it's tagged with a radiotracer called fluorine-18. And fluorine-18, when it breaks down using positrons. And positrons allow us to use something called coincident imaging, which I won't bore you with. But it's a very good means of evaluating metabolism in the cell, and particularly in the brain. So the metabolic issue is that cells that are more metabolic take up more of the 18-fluorodeoxyglucose, and cells that are less active take up less. And we can make that into essentially a heat map of the brain. In MSAP patients, there are specific decreased areas of FDG activity in the putamen, the pons, and the cerebellum. And the cerebellar peduncle, sorry. We can use that to differentiate MSA subtype P from Parkinson's disease and another mimic of MSA, which is known as progressive supranuclear palsy. Both of those entities have more extensive hypometabolism. This is a PET scan. And what I'd like you to do is I'd like you to pay attention to the top line, okay? The first case is a normal control. The second case and third case are different variants of Parkinson's disease. And the third case is a case of MSA subtype P. In the first case, we can see that the brain is fairly hot. There's red and yellow throughout the brain, particularly centrally. Now take a look at the MSAP patient. There's a lot less activity here in the lentiform nucleus. The red and the yellows that we were seeing in the normal patient, we're simply not seeing there. And this is suggestive of an MSA subtype P on a PET scan. The two series on the bottom are specific radiopharmaceuticals, and I'm not going to get into those as I believe they're research oriented. I've been asked to speak a little bit about fMRI. fMRI is functional MRI, and what it is it is MRI scanning while you are completing tasks. The proxy for this is that you measure regional cerebral blood flow, and that regional cerebral blood flow is very similar to a PET scan. It serves as a proxy for metabolic and neuronal activity. The advantage is it's like a PET scan without the radiation dose that is present with the 18-fluorodeoxyglucose. Unfortunately, the way the protocol is currently, I believe this is being done on an investigational basis at the University of Florida. They take 2 scans 1 year apart, and the 2 scans are then compared. So as there is no clear baseline right at present, you would have to wait a year for your diagnosis. That may not be acceptable to some patients. The other thing I feel compelled to say is that in the last year or so, there have been some questions as to the statistical validity of the fMRI algorithms, and I don't know that they have been fixed. So there may be some issues with that. As we saw this morning, bladders are very helpful in the diagnosis of MSA, as well as one of the sources of patient complaints. Bladder imaging can also shed some light on MSA proclivity by serving as a proxy for evaluating autonomic functions in the bladder. We can take an ultrasound and look at the bladder, pre and post void. If there is a large post void residual, we are suspicious that there are problems emptying the bladder. It won't be clear to us why those problems are happening, and there is a differential diagnosis. It's not only autonomic problems, it could be something in the spine, it could be a functional obstruction where you have a stricture in your bladder, or even something like a bladder diverticulum. So there's more investigation that needs to be done, but it's a fairly quick and easy way to evaluate if bladder function is okay or not. A similar study that can be done is a voiding cystourethrogram, and that's done under fluoroscopy, and that's where we put dye into the bladder, fill it up, and then we watch it empty out. And that's a little bit more of a dynamic study. I'm not going to go into the urodynamic studies because that's something that urologists do, and I'm not really qualified to speak on that. Another way of evaluating the autonomic nervous system is through a nuclear medicine gastric emptying study. And this is where we take a standard meal, usually 2 eggs, toast, some orange juice, and we put a little bit of technetium powder into that, which is countable on a gamma counter. And we time and watch the exit of the solids and liquids from the stomach. And delayed egress of the ingested items from the stomach is an indication that there is a problem with the autonomic system on the stomach. We have to be careful because the most common cause of gastroparesis is going to be something like diabetes. And you can have diabetes and have MSA very easily at the same time. I'll mention the swallowing studies that we assist the speech pathologists with. Speech pathologists will feed you different substances, feed you different thicknesses and consistencies, and we see if you are at risk for aspiration and to what degree you can eat. And that's something we can talk about a little bit later in the question and answer session if that's of interest to people. Before we had all these advanced tests, there was a radiopharmaceutical called MIBG that was used for diagnosis of Shy-Drager. And it's actually not a bad radiopharmaceutical. It's not as good as the studies that I've told you, but it's still something that could be used if there's a really equivocal diagnosis and we're not sure what we're dealing with. So that's also in our armamentarium as well. Finally, I'll mention the DAT scan. And this is a specific radiopharmaceutical, ioflupane. It's used with SPECT, and SPECT is, for lack of a better term, is kind of a poor man's pet. It is useful for differentiating between essential tremor and Parkinsonian disease. However, it does not differentiate between Parkinson's disease, MSA, or progressive supranuclear palsy. So it's useful to rule stuff out, like a CAT scan of the brain, but it won't necessarily rule anything specifically in. I'll speak for a few minutes about interventional procedures, and as an interventional radiologist, I have placed quite a few feeding tubes and gastrostomy catheters in my career. And when a patient is not able to feed themselves, you have to evaluate why. Is this a temporary condition or a permanent condition? And some patients are just, really just overwhelmed in the course of their particular disease by something that is possibly treatable, curable, resolvable. And in that setting, okay, a temporary feeding catheter, like a Dopphoff catheter, is a reasonable intervention. What a Dopphoff catheter is it's like a nasogastric tube, a tube that's put through the nose and threaded down to the stomach. But the Dopphoff catheter is advanced further, past the stomach itself, into the small bowel, past an area called the ligament of Treitz. And the reason that we do that is that we believe that passing that area of the bowel makes it less likely for the feeds that we give to the patient to reflux into the stomach and then be aspirated again. So the Dopphoff catheter is usually, or jejunal feeding catheter, is usually a temporary intervention that an interventional radiologist would do for feeding for a period of time. Now, after about 2 to 4 weeks with that catheter in, if you're not getting better, you have to make a decision, do I want an actual feeding catheter or not? And an interventional radiologist could be called upon to place a feeding tube, just like a surgeon would, essentially. We do it a little bit differently. The technique I don't think is as important, but we can put a gastrostomy catheter with a jejunal feeding catheter as well. We go from the outside. Gastroenterologists will put a endoscope down, and they'll go from the inside. Just a different approach of doing things. It just depends, who you refer to and who you kind of, feel will do a better job. We can talk a bit about those issues as well at the end. There are a few take-home points I want to give to everybody today. And I think that the number one point is education is key for inclusion. With rare diseases, there is, different levels of education among the population. I mean, not only the patient population, not only the caregiving population, but the physician and treating population as well. They just have different levels of, understanding and familiarity with the disease. The more we educate people as to what this disease is and how best to diagnose it and treat it, the more diagnosis and the better treatment we will have. I believe that the small number of patients that exist with a syndrome such as this argue for registries. To get involved, to share your experience, to share your data with other patients and ultimately the larger medical community, I think is very beneficial. Because better data means that we have better odds for everybody. We have better odds for doctors to make the right diagnosis. We have better odds for patients to get the right treatment. We have better odds to keep you as healthy as we can, as long as we can. I'm a big fan of patients' rights and patient empowerment, and I believe that online communities make that possible. You need to be aware that some online communities might be data mining you and selling your data. So choose the right online community carefully. Also be aware that not all information on the internet is true. So use some common sense. Ask a trusted physician or caregiver their opinion before you take anything as gospel. I'm going to end up and I'm going to explain to you, as a physician, we are really trained to want to cure. We have a bias in physician culture that we want to cure people, when in reality, most conditions are chronic, and most of the time we cannot. And that is a frustration that exists in ourselves as physicians. But there is opportunity, and I think the important point is that even when there is not a cure available at this time, it doesn't mean there will not be a cure available at some point in the future. But even when there is not a cure, there is an opportunity for healing. We can heal not only ourselves, we can heal our relationship with ourselves, we can heal our relationships with others, we can heal our relationship with our family and our community. And I really urge you that when faced with a serious diagnosis, seek out healing. And I wish you all the best, patients and caregivers alike, in your journey to knowledge. Thank you very much.
You mentioned earlier that there are better MRI machines than some of the older ones. During the progress of this disease, unfortunately, many times you might have to get an MRI. How do you know if the imaging center you're going to has an old decrepit machine or a better one?
I have to be careful what I say because I want to be politic. I think that is reasonable to request a machine that operates at 1.5 Tesla or 3 Tesla, and it is a closed magnet, not an open magnet. I think it's reasonable to guarantee that the magnet has been ACR certified. That ACR, American College of Radiology, certified.
Would an imaging center tell you all this?
Yes, the imaging center has to, I believe that they have to tell you that. And depending upon where you are in the diagnosis process, clearly if you go to a university medical center, you are going to have probably one of these higher field magnets present. I don't live in Jersey, so I don't know the state of New Jersey. I do know in Florida there are older magnets around, though these clamshell open magnets, they're advertised, or a stand-up MRI or something like that. And some of these are lower field magnets. And I think they're fine for what they do, but I think in this particular circumstance, I think that for real neuroimaging, where neuroimaging is important and it really is a make or break study, I think you want a good closed magnet, high field, with a neuroradiologist reading the study.
Okay, and what was the first thing you said, 1.5?
Yes, 1.5 Tesla, T. That is the measure of magnetic strength.
Thank you.
Sure.
Over this way. Is there a significance in knowing the difference between a diagnosis of MSAC and MSAP?
Prognostically, I do not know. I think that the significance is that you can then know the likely progression of symptoms. Are you going to be more likely to be ataxic, or are you going to be more likely to be Parkinsonian? I think that that's relevant. If you're Parkinsonian and you're having a poor response to levodopa, well, then you shouldn't be probably taking it, and you should be trying something else. So I think it's not as much of a prognostic implicator, but a treatment-related differentiator.
The unfortunate truth here is that while there is some diagnostic capability, ultimately it takes autopsy. It takes brain donation. So when you're talking about what you're seeing on these slides, how does that correspond to what they're looking at in a postmortem? I guess really what my question is, looking at the scans that you're showing of a live patient,
Right.
how does that compare to what they look at postmortem? Will it confirm? Does it really help? Would that?
Yeah, no, it's really helpful. I think that, so the brightness, okay, and the high signal, okay, I'm going to refer to brightness and high signal interchangeably here. That brightness or high signal that exists in those areas of the brain that we're looking at are indicative of disorder in the neural tracts. It's indicative of inflammation or infection or some sort of breakdown, okay? So when you slice that section under the microscope, okay, you are going to see dying cells. You are going to see cells that are not working correctly. You are going to see inflammatory changes or fibrosis or, you know, just different changes that will correspond to the imaging appearance. So yes, it's shadow pictures, okay? But there is a good correlation between what we're actually seeing and the pathology that exists. In terms of feeding is a tricky issue. And because here's the problem. Once you have a tube in, okay, the tube kind of takes on a life of its own, and nobody wants to take it out. And if it's not working well, it needs to be changed. And the focus on becomes more on the tube than necessarily the patient sometimes, and it shouldn't be, okay? But you know, it's just practically how sometimes these things happen. If it's a temporary feeding tube, what is the purpose of the temporary feeding tube? The purpose of the temporary feeding tube is to get you over the hump of whatever, you know, intercurrent process that you've had that requires you to be fed to maintain proper nutrition and calories, but not necessarily, you know, have a permanent placement. Now, if you cannot eat anymore, all right, if you can't eat, then the question is the feeding tube appropriate? What is the patient's quality of life? Not according to us, according to them. What are their wishes? And that's part of the reason, you know, why my colleague, you know, Amy suggested that you need to have these hard conversations early. You need to have the ability for your caregivers to know what it is you want. Because do everything becomes aggressive sometimes. You know, we live in a world that has legal implications and realities, and you know, do everything will mean do everything, whether that is comfortable or, you know, necessarily life prolonging for the patient. So, if I have a good quality of life but I can't swallow, well, I'll shoot the Ensure in through my gastrostomy catheter. Okay, if my quality of life is poor, you know, and I'm on hospice and I am, you know, expected not to do well on an aggressive basis, what is the purpose of the intervention? Everything has to be taken in the circumstances that it lies in, and a decision, the talk should be done beforehand, but the decision should be taken in light of the circumstances, quality of life, and likely outcome.
Hey, thank you for the talk. It was great. I believe I heard you said that an interventional radiologist would be someone who would put in a feeding tube.
We could, and
You
it
could.
could be an interventional radiologist, a surgeon, or a gastroenterologist.
I see. Okay. So you have choices, and it sounds like those choices are made. I guess what I'm asking is, are those choices always something that the patient could make and have all three of those available and decide, or is it somewhat based on insurance or who's working at the hospital? Or
Yes,
yeah.
I think you can express a preference. I think also, you know, it depends upon what services are offered at the hospital.
Right.
You know, interventional radiologists are not the most common of birds, so you know, you may have more gastroenterologists available at the hospital than IRs. You know, particularly at a smaller hospital. And they may do just a fine job. You know, a surgeon can also do this as well. It just really, you know, it depends upon really existing referral patterns in the community and who you're most comfortable with. You know, and if there's someone that's available, yes, you know. But I'm just letting you know that each of these three types of doctors do these procedures, more or less.
Right.
Not all gastroenterologists will, not all interventional radiologists will.
And are there other procedures like that interventional radiologists do?
Yeah, we have a tremendous
Ah,
litany of procedures.
okay. Yeah, that's great. I just had never heard of that particular specialty before. So
It's a
good to learn more about.
it's a fellowship. It's a fellowship after radiology, just the same way as a neuro fellowship is. Yeah,
Thank you.
you're welcome.
I'm intrigued by your assessment of the PET scans. My father-in-law, the same week that he was diagnosed with Parkinson's, was diagnosed with sarcoma. And his doctors opted to table the Parkinson's issue and deal with the cancer. And he had surgery, radiation, chemo. And he was followed for 2 years with full-body PET scans. My question is, those PET scans that were done back at that time, if people weren't looking for the changes that you've pointed out, would they say something?
I think if you were looking to rule out sarcoma, to say, hey, by the way, your patient has MSA, by the way, that would be a.
But he was diagnosed with Parkinson's. It wasn't until 2 years ago. The cancer and Parkinson's was 2008. And 2 years ago, we learned about the MSA, and it was actually through a chain of events. No professional actually told us. Somebody who read the record said, hey, did you know that he has MSA?
I think if someone diagnosed that on that particular PET scan, I would probably be like, wow, that's a great rad. It's and realistically speaking, depending upon the resolution, okay, that was performed, it may not be possible because it was a whole body PET.
Right. So they
as
may
opposed
not
to
have seen what you
yeah.
see. Okay. That was my
So
question.
I think that would be reasonable. It just depends upon the scanner that was used.
Thank you.
Sure. All right. Thank you very much.
Thank you, Steve.